ever wondered what would cause a large knot or bump or an area of skin that looks lumpy on a person's upper chest? I know I have. Hi, I'm Phyllis Garnett, founder of the Garnett Cancer Society nonprofit. Our mission is to decrease the fear of the word cancer by providing you with professional, educational, personal testimonials, and resources of information to you and our community. Today we have with us Dr. MANGESH OZA. Dr. OZA is a fellow of the American College of Surgeons. He practices general surgery with Meritus Health Comprehensive Surgery in Kansas City, Missouri, where he specializes in breast health, colorectal surgery, endocrine surgery, general surgery, and laparoscopic minimally invasive surgery. Dr. OZA will help us to understand as he explains what that large knot or bump or raised skin on a person's upper chest actually could mean and be. Hi, and welcome, Dr. OZA. How are you?
I am doing well. Thank you for asking me to speak.
Yeah, I am so glad that you're here, and I thank you so much for taking time out of your busy schedule to just talk with us and give us some highlights and information on cancer. So we're just going to jump right in. You know,
sure.
I see, as a general surgeon, I see that you wear 5 hats, specializing in 5 different areas. And I'm very familiar with 2 of those hats that you wear because of my love for science. I'm familiar with the endocrine system. And I believe that involves hormones from the thyroid, the adrenal, and pancreatic glands. Am I correct?
Yeah, and many, many more. The hypothalamus, the pituitary, but I don't necessarily operate on those areas. But yeah, my focus has been thyroid, parathyroid, and occasionally adrenals, although adrenal pathology is not very common. So most of my focus has been endocrine, thyroid, and parathyroid.
Okay, awesome. Well, the second hat that I'm familiar with that you wear is breast health, or as I put my spin and twist on it, healthy girls. Can you give us some specifics about these 5 hats that you wear?
Sure. As a general surgeon, I was trained in a wide variety of things, and we all are. I was trained in New Orleans at the Ochsner Clinic, and at that clinic, they had a huge tertiary and quaternary referral center from South America and Central America. So we got exposed to a wide variety of diseases that we may not sometimes see in the US. Mm-hmm. And although a lot of surgeons do trauma, I wasn't terribly excited about that or interested in it, but I got very interested in the oncology aspect. And so with that, I focused on the oncology side of things. Breast cancer is certainly a huge part of oncology. So I do a lot of breast health from normal breast pathology all the way to breast cancer, endocrine, of course, thyroid, parathyroid, and then I also enjoy any of the alimentary, meaning the intestinal cancers, so esophageal, gastric, small intestine, colon, which then lends itself to diverticular disease. Right. And then, of course, almost all general surgeons take care of gallbladders and hernias, which I do as well.
Oh, wow. That's awesome. Yeah, you're wearing those hats, and I know that the community and your patients are very appreciative for it. If I recall correctly,
well, thank you. Yeah,
you are so welcome. If I recall correctly, our first encounter was about in 2010 when I had a cyst in my right breast, and I believe, was that fibrocystic? I can't recall, but I would like for you to share with us what causes a cyst, and do cysts hurt?
So it is a normal variance within women's breast. And I think the best way to explain it is the breast architecture, the pathology within a breast, the normal variance within a breast varies, just like anything else in our life and in our bodies. And so to have a cyst is not necessarily considered pathology, but it is a normal variance within women's breasts. So cysts can develop within women's breast as early as their teenage and early 20s, and can be part of a woman's breast anatomy for decades beyond that. These are just dilated areas within the breast tissue, that collect fluid. And sometimes these are either simple cysts, which are basically just fluid-filled sacs, or they are complex cysts. Complex meaning fluid-filled sac with partitions in there, dividing it into different compartments, or debris floating inside of there. And so that's the first thing that breast physicians sort of decide. Is it a simple cyst or a complex cyst? Simple cyst really means nothing. Other than potentially causing pain and discomfort, it really doesn't need to be treated at all. There's no need to do anything for them because they do not carry any inherent risk for breast cancer. Complex cyst, on the other hand, we follow. They're more than likely benign, but we follow them because complex cyst might have some other pathology associated with it, hidden behind it, that needs to be evaluated. And of course, if we're worried about a complex cyst, we would probably biopsy it to confirm that we're not missing a breast cancer that's adjacent to that cystic structure. So again, a normal variance, not necessarily pathologic, but it can be worrisome if they're complicated, complex cyst with more pathology behind it.
Yeah. So then evidently I had a complex cyst because I had a lot of body fluid coming from my right breast when I had that cyst. Mm-hmm. And when that happens, and so you said that usually it's a biopsy. I don't recall that I had a biopsy at that time, but you did do surgery and remove that cyst. I heard you say that not all cysts are benign, but what would cause a cyst to become malignant?
Cysts don't become malignant. What happens is you find a cyst on sonogram that looks benign, and you either decide that it needs to be left alone, nothing to worry about, or followed because there's some additional pathology adjacent to it that might be worrisome, or 3, it is worrisome now, let's proceed with a biopsy now. So cysts necessarily themselves don't transform into a breast cancer. It's the fact that sometimes cysts are adjacent to other pathology that might be hidden by that cyst. And so I don't want women to think that they have cysts and that puts them at risk for breast cancer. It doesn't work that way. Cysts are a very normal finding within women's breast, and majority of the time, like probably in the high 90s, we would leave it alone unless there was adjacent worrisome pathology.
Really, really. So now what about with men? Because I have a question in reference to, I hear that there can be fatty tissue or a cyst or a tumor. Now, do you find these in men as well as in women? And then are all 3 of medical concern?
So fatty tumors are, so if you look at just going down to basic anatomy, the anatomy of a woman's breast or male breast even is you've got skin on the outside, and then you've got a adipose tissue, fat, that comprises of the breast, and then breast tissue. And the part that we're of course focused on is the breast tissue part, and that's the tissue that develops into a woman's breast, that also can be pathologic down the road, either become cyst, create nipple discharge, or in rare instances turn into breast cancer. Men have the exact same structure, but because we don't have the hormonal stimulation, we don't develop breast tissue, a full enlarged breast like a woman does. So men also have breast tissue there, but it's inactive, it's involuted, it's very small. So all men have a tiny amount of breast tissue there. And then if it's stimulated by hormones, then it can turn into a developed breast. So yes, men can have all of those pathologies, but men generally don't have them because we never develop we don't get the hormonal stimulation that women get through puberty.
Oh, okay. Thank you. Dr. OZA, after you received my mammogram report, what caused the urgency for the medical actions that you suggested when you talked with my husband, Ron, and I? Do you recall?
Would you give me permission to access your chart so I can look at that now and talk about that specifically? Sure. Okay, I have your chart up in front of me, so if you'll just give me a minute, I'll look at it. And you're okay with discussing your medical history live like this?
Yes, okay. I have given permission and signed up for it.
Oh, all right, very good. So we met, you're talking back in May of 19. Is that the time you're referring to?
2019, yes.
Yeah, 2019, and May is when we met. Exactly. And at that time, at the right breast at the 10 o'clock, you had a 1 centimeter mass that we identified and sent for a biopsy. And so, unfortunately, that's the mass that was diagnosed as a breast cancer.
Mm-hmm.
And so, let me just pull up. Let me see if I can access the mammogram from back then. So what I have, what I've recorded here is that you had a 1 centimeter mass at the 10 o'clock area that was identified on sonogram. And that's the one we targeted for biopsy.
Right. Mm-hmm.
Right.
Yeah. And so having that, I know that Ron and I, we had a lot of questions. We had an awful lot of questions. And I just want to thank you so much for your patience as you explained everything to us, Dr. Oza, your empathy, your patience, your concern with us just helped to decrease our fear of cancer and of the unknown. And not only what did you do that on that initial appointment, but you did it throughout every appointment we had with you. And so I, from my heart and my husband's heart, we thank you so much for that, because it was very, very scary.
Well, you're most welcome, and I appreciate the kind words. It's important for me, for my patients, to understand what they're going through, because I'm here just to guide them through it.
No, thank you. Thank you. So quickly, I know for our viewers, a lot of people are concerned and have that, nervousness of surgery. They have the old myths of if you get opened up, then air is going to, cancer is going to spread and all that.
Yeah.
And they don't even know the steps to take. I didn't know. I knew that after I had a mammogram, then there were steps to take. Would you take us through the following steps after a mammogram, after you receive the report? And I'm going to bring some pictures that will, I guess, apply and associate as we go through some of these.
So first of all, it's very important to get screened. So screening mammograms are very important. Generally, we recommend a baseline at 35, and then generally at 40, a woman should start getting annual mammograms. If an abnormal mammogram arises, then it's important to visit with your physician at that point, because we need to determine if that's a new abnormality or was it seen on prior mammograms. And so the scary parts can come when you've never had a mammogram and there's an abnormality, because you never know. It may have been there for a very long time. You just didn't know about it.
Right.
But if you do get a mammogram abnormality, the report will probably at the bottom tell you the severity of it and how worrisome it is. If you look at the bottom of the report, it'll tell you what's called a BIRADS category. BIRADS, it's an acronym BIRADS, and that is numbered 1 through 6. So it's a way for physicians and clinicians to understand how serious, how abnormal a mammogram is. So when Phyllis, when we first met, you had a BIRADS category 4 abnormality. And what that means is, if you look at a BIRADS 1, that would be a mammogram, and we don't do this, but if we did a mammogram on an 18-year-old girl, that mammogram is going to be completely fine. 18-year-old women do not get breast cancer. It's exceedingly unheard of, exceedingly rare. So that would be a reference point. A 2 mammogram would be benign cyst. This looks like there's a mass, but it's a completely benign cyst, nothing to worry about. You just need a yearly follow-up at that point. 3 is where it starts getting a little more complicated. If you have a BIRADS 3, then that requires at least a 6-month follow-up mammogram or sonogram, and maybe even an additional sonogram if they couldn't see what they need to on a mammogram. When you get beyond 3, that's when surgeons get involved and biopsies are needed. 4 means there's a 15% chance that there's a breast cancer associated with that. And so, 15% chance that there's an abnormality, not breast cancer, 15% chance that there's an abnormality associated with that that's going to require some further surgery. So 85% chance it's going to be benign. And then when it gets to BI-RADS 5, that's when the odds start turning the other way, in the sense that there's a high likelihood that there's a malignancy, about an 80 to 85% chance it's a malignancy.
Right.
And so once you have an abnormal mammogram, it's important to speak with your physician and get the appropriate referral to a breast surgeon if you're in that 3, 4, and 5 category.
Mm-hmm. Mm-hmm. So I know that after I had the mammogram and we talked, then you scheduled a biopsy. And I'm just going to share some things about that. Here, this is just my HIPAA notice to let everybody know that we are HIPAA compliant to share my medical information. So when I had the biopsy, you and I, let's see, there we are. And getting ready for, we were getting ready for this is the day.
I remember that day, yes.
Yeah.
Yeah.
And you know what? This was July the 5th, after the 4th of July. And so you had scheduled, this is the day I was scheduled for surgery and the biopsy. And so can you explain what happened here? Because
sure. So
I had the biopsy.
You had a needle. First of all, back in May, you had or maybe it was June actually, you had a needle biopsy performed that confirmed that this was a breast cancer. So your diagnosis was what's called invasive ductal carcinoma. And based on that diagnosis, you and I met in the office with Ron on June 20th, and we talked about the various surgical options. Mm-hmm. Basically, there's 2 options for a woman. One is to do a lumpectomy, which is called breast conservation therapy. And that's what you chose. The other option would have been to do a mastectomy. So you chose lumpectomy, and therefore, for me to identify where the mass is, the radiologist on the day of your surgery on July 5th had to put a thin little wire to mark that spot. So that's what that represents, is a thin wire inserted into your breast with the tip of that wire at the cancer. And so after you were asleep, I made an incision on your breast, found the wire, traced it down to the tip of the wire, and removed the tissue surrounding the tip of that wire. And that's what was a lumpectomy. And then separately, I made an incision under your arm in the axilla to do a lymph node biopsy called a sentinel lymph node, which means I removed the very first lymph nodes in the chain lymph nodes to try to preserve all of them. Instead of removing all of them that surgeons used to do many decades ago, mm-hmm. we now just remove the very first few lymph nodes, 1 or 2 lymph nodes, and then test those.
Okay. Now, should lymph nodes, that's a good point that you bring up. Should lymph nodes be examined like we do our breast? I mean, is there a concern for that?
You mean on a self-examination?
Mm-hmm.
Yeah. So it's important. That's a good point to make, because it's important to understand that a woman's breast is almost a teardrop shape. So not only does it incorporate the tissue up in the front here, but it also, if you imagine, it tapers like an ice cream cone. So if you imagine an ice cream cone with the tip of that cone up in your axilla and the ice cream being the breast part, the cone is where you really need to examine all the way up into the axilla, because that breast tissue does extend up that high. And so, yes, it is important to extend your self-examination up into the axilla, where there's a small amount of breast tissue there. You inadvertently will feel some lymph nodes there, but again, lymph nodes are difficult to examine. If they were abnormal, they would be fairly obvious, but even an abnormal small lymph node, you would not be able to feel necessarily. But to examine the axilla is important because the breast tissue does extend up to that direction.
Okay. And so this slide that I brought up now, this is like where the needle would have been. And
exactly.
This
Perfect.
The tumor.
Very good representation of what we did for you. The wires dangling out of you. I made an incision right where the areola meets the skin, mm-hmm. Right at that junction there. And then sort of went exactly where your cursor is up to the wire, and then found the tip, found that wire, and then knew that we needed to get widely around that. So that was removed. That purple mass was removed.
Here. Okay.
Right.
All right. Thank you. Wow. It's a lot to it. So then after the surgery, the next thing was, I guess, the port.
Correct. Yeah. So based on your pathology report, we needed to perform a port placement. And give me 1 second, and I'm going to pull up your path so I can speak more specifically.
Sure. And I just pulled up a little slide here that kind of helps to understand what a port possibly looks like and the different parts of it, because I definitely didn't know. I made a joke about it just to keep things light and said that I was a robot. I had this, and I would, my grandchildren, when they would come and they would see this, large knot on me, they were like, Nana, what is that? And I would tell them, I'm a robot. I'm a robot. And that helped to keep them from being fearful as well.
Yeah. So in your specific tumor, you had a relatively small cancer in the grand scheme of things. Your tumor was 11 millimeters, which is basically roughly a little bit bigger than a third of an inch, maybe the size of a marble. And the tumor was completely removed. The margins were negative. Your lymph node that we biopsied was also negative. But because of that biopsy of the lymph node and the mass, the oncologist reviewed that, and they were a little bit concerned about the size of your tumor because it was just above 10 millimeters. And the fact that it was grade 3. So grading gets a little more complicated for patients to understand, but it's important to know that grade has nothing to do with stage, but grade is another way for physicians to determine how aggressive the cells look under the microscope. And unfortunately, yours were grade 3, which is the most aggressive looking under the microscope, whereas grade 1 would have been an indolent tumor. So because of that, I believe the oncologist made a determination that you need to have chemotherapy, and that's where they asked us to put a port in.
Okay. And so this is kind of what the port looked like or could look like.
Yeah. So not all women get ports, but your tumor warranted it.
Okay.
Yeah. So not all women need chemotherapy, I think is a better way to put it. But some women can, and many of them actually, with early stage tumors, even though yours was a stage 1 cancer, you still needed chemo. But many stage 1 cancers are treated without chemo and only with anti-hormone therapy, which is tamoxifen, because you're estrogen positive. So that's the typical course. And I would say yours, they had some concerns based on the biology of your tumor, meaning how aggressive it looked under the microscope. And that's why they said so individualized care for you was that you needed chemotherapy.
Yeah. Okay. And I believe that here's what a port where the position internal would be, like under the skin. Why are ports placed here? I wanted, remember I asked you if my port could be placed somewhere else, so when I put on my bathing suit, it wouldn't show.
Sure. So port placements are a bit of more of a style for surgeons. So they can be placed in various different locations. The basic tenet of port placement is that the catheter part, that wire part that you see there, the tubing part, needs to be in a major blood vessel. So it's either the internal jugular vein, which is in your neck, or it's in the subclavian vein, which is that vein below the collarbone, because both of those veins then drain towards the heart in the mid portion of the chest. So all ports are placed into those veins, but the actual port part, the part that patients see, can be placed nearly anywhere, either high up next to the collarbone or low onto the chest. And that's where I say the style part comes in. The issue is, imagine it's just like any other plumbing. The longer the tube, the more likely there's going to be complications. It can kink, it can twist, it can get clotted off. And so just over the years, I've learned to keep that tube as short as possible. And in doing so, your port's placed basically as close to the vein as I can get it to allow it to function long-term, because you're going to need this port for many, many months.
Yeah.
And the more movement you have, the longer the tubing is, the more complications that can arise. And so there are some surgeons that place the port much lower onto the breastbone, but it's fraught with some complication risk where the catheter can move, the port can twist, the port can get a kink off, and then you'd run into other issues that require more surgical procedures.
Yeah. And this is actually the position. This is my port that was
right.
there.
And the other main reason to put it there is we have to anchor the port. We have to sew it in place up against the muscle. So you can't really go any lower because as you might understand, any lower means there's breast tissue, and then the port is so much deeper inside of you that the nursing staff can't access it. So that's sort of the thinnest part of a woman's breast is right up there up against the collarbone. And so another reason why I tend to favor putting it there. It's a lot easier for the oncology nurses to access, so you're not poked over and over, and they don't miss accessing it, because if they miss accessing it, it's a horrific problem. They're squirting chemotherapy into your breast rather than your vein, and it can cause a pretty severe burn to the skin and the breast tissue.
How long are ports left in, and when do you determine when it comes out? Because I think this is after my port was removed. Woo-hoo.
Yeah.
And I have a very nice smooth scar, so yeah. Yes. How soon do you determine that?
It's actually relatively simple. Basically, you take the port out whenever the oncologist says it's time to take it out. Ports can last a very long time. I've had patients leave ports in, not for breast cancer, but for other diseases for many, many years. As long as it functions properly, doesn't get infected, and it's not clotted, it can last you many years. But there are some long-term consequences of leaving a port in, and that is that the vein can scar around the port and then narrow and cause long-term complications. So whenever the oncologist is finished with chemotherapy, it's time to get the port out. Usually that's somewhere between 3 and 6 months from original placement. And if the port is needed for longer, it can stay longer. Some women need treatments for up to a year if they need Herceptin, a different type of treatment for their tumor. That in those scenarios, we leave the port in over a year.
Wow. And then you can see that this is the picture of my souvenir.
Right.
It's just a picture. I don't have the port itself, but this is how it actually looked. So yeah, thanks a lot so much for giving us that information and sharing. I heard you talk about a lumpectomy versus a mastectomy, and I was given the option of either or both. I mean, either one. I chose the lumpectomy. Do you see more lumpectomy surgeries versus mastectomies? And if so, what would be the reason for that?
It's interesting. It is not that I see more, but it really, I think the interesting part is that it should always be a woman's choice if it can be, meaning that every woman is a candidate for lumpectomy. Every woman is a candidate for mastectomy, as long as there's some parameters that are met with size of cancer and it doesn't preclude a lumpectomy. Or a woman that has multiple breast cancers ought not to do a lumpectomy. But as long as those rare instances aren't present, a woman should have the option of choosing either one for herself. And that's what our initial meetings are always about, is to explain the difference between the two. And the main difference between the two is that the lumpectomy requires radiation, whereas mastectomy generally doesn't. And it's a one-night stay with the mastectomy, whereas a lumpectomy is outpatient surgery. So as far as what women choose, it is literally all over the board. There is no, after doing this for so many years, it's really, I've learned it really is a woman's personal choice. So I've had 30-year-old women choose mastectomies. I've had 80-year-old women choose lumpectomies. I've had 50-year-old women choose bilateral mastectomy. There are some societal trends, I think, that we see nationally, that some, as the media propagates some more information about breast cancer, we have a lot more women choosing mastectomies because they become fearful. I noticed this trend. We all noticed as breast surgeons. We noticed, for example, if you might recall, when Angelina Jolie underwent bilateral mastectomy because she had the BRCA gene. Well, all of a sudden, we had a lot more women choosing double mastectomies. Exactly. But maybe somewhat unnecessary in the sense that they weren't BRCA positive, but it was just more out of their concerns and their fears, and that's okay. It literally is it is a woman's choice. But our job as breast surgeons is really to present the all of the facts, present all of the, answer any of the questions that a woman might have, and then let them make the choice, because it really boils down to a personal choice, because the outcomes are exactly the same. You're not choosing an inferior operation because you got a lumpectomy, and you're not getting a better operation because you got a mastectomy.
Okay. Now, and I know our time is getting past us. So quickly, I know that one of the surgeries that you perform is laparoscopic minimally invasive surgery. Is that the type of surgery that I had?
So laparoscopy is a completely different. Laparoscopy refers to surgery done inside the abdominal cavity for the stomach, the intestines, the colon. And so there is no such thing as laparoscopic surgery for breast. So you had breast conservation therapy, which is our version of minimally invasive breast surgery, because you didn't have a mastectomy. But laparoscopy is something that you don't need, and we wouldn't do that for this. So
okay, I remember the minimally invasive part, so I said, okay,
right.
What I had. So now, did I have a robotic type of surgery at all?
You did not, and robotic surgery really hasn't been applied to breast surgery, only because the access. So robotics is interesting. Surgeons use robotics in areas of the body that are very difficult to access, meaning deep inside the abdominal cavity, behind the pelvic bones, areas that are difficult to access. The robot makes it a lot easier to visualize and to access and to operate upon. None of that is necessary for breast surgery, because the access is all superficial. We're not inside any chest cavity, and so robotics really hasn't been applied to breast surgery.
Do you recall the youngest male and or female that you operated on for breast cancer?
Unfortunate 23-year-old, that 23 or 24, I believe. It was a very long time ago, but yeah. And she had breast cancer because of she was hereditary breast cancer, BRCA positive. Her mother also had it. So yeah, unfortunately, we sometimes have to operate on 20-year-olds, and that's very uncommon, though.
Yeah. Do you mind sharing the race of that patient?
That one was, I believe, Jewish, and so she had some Jewish origins.
Okay, because the reason I ask is because I know statistics show that the highest rate or incidence of cancers are found in the Black-brown race, and so I was concerned if that might be the cause as well.
So race, interestingly, does have a role in breast cancer, in the sense that if you look at just sort of a bird's eye view, breast cancer, about 1 in 8 women are going to get breast cancer. It's a staggering statistical odd. 1 in 8 women. I mean, you go to any lobby of any doctor's office, or you go to the movie theater and you just count out 1 in 8, and statistically, those women, someone's going to have breast cancer in that movie theater, or in that restaurant, or in church, wherever you are. So that is the sort of the bird's eye view. As we look deeper into race, there are some women that, some races that have a higher propensity for breast cancer. These are some very unique subsets of Jewish populations that can have a higher risk. Family history, of course, plays a significant role in a physician's heightening their awareness. That doesn't mean just because your mother had breast cancer that you're going to get it, but it certainly heightens a physician's attention, in the sense that we need to be vigilant about it. Studies have shown that sometimes African-American women have a slightly higher risk of breast cancer, but if you look a little deeper into that study, it's more actually that they don't do as well as white women do. They may have the same exact risk factors, and they may actually have similar rates of breast cancer, but unfortunately, their breast cancers are found a little bit later in their stage, meaning they're a little bit more advanced breast cancers, and in turn, they don't do as well because of it doesn't get caught early, basically. And so that's where race has a huge impact in survival from breast cancer, in the African American community, in the Latin American community, in the Native American population, and even in Asians.
Really?
There are some studies in Asian ethnicities that it's a cultural thing. I think women tend to, in the Asian community, don't seek medical care as readily as they could, and again, present later in life or later with more advanced stages of breast cancer and tend to have a poor prognosis.
Wow, and
so there's a lot of variations.
We don't even hear about.
Yeah, there's a lot of variables that factor into this, and it's socioeconomics, it's cultural biases, it's the old, we all have probably heard of grandmothers and great grandmothers that in the 1940s and 50s, if you got cancer, you just shied away from society. You didn't mention it. It was taboo to mention that you have cancer. And so some of that still is pervasive amongst cultures in the Islamic community and in the Middle Eastern community, as well as in the Asian communities. And that it's sad to see, but the more awareness we get out there, just like what you're doing, the more awareness that gets out there, I think the more, the better it'll be for all of us.
Yeah, thank you so much. I know that our time is short and that you have a surgery to get to. So Dr. OZA, as we complete our interview, what words of wisdom, what words of advice would you impart to our viewing audience today?
I think if you do get presented with, if you're unfortunate enough to have an abnormal mammogram, I think it's important to understand that you may not have breast cancer. So don't go into denial. Seek out all the attention, all the information as you can. Speak to your physicians. Ask for the second opinion if you think you need it. If you do get diagnosed with breast cancer, understand that nowadays it's very treatable. It is, we have so many new advances in chemotherapies and in adjuvant treatment options. Radiation is very well tolerated. So you shouldn't be scared of the treatment because it is very well tolerated nowadays. And it's just really important to get the screening done and to follow through with the recommendations of your physicians.
Yeah, thank you so much. I so appreciate you for taking time out of your schedule today, for sharing your expertise with us in general surgery and the various types, explaining the possibilities and causes and effects and the various procedures and outcomes. It's been my honor, and I appreciate you and thank you so, so very much.
Very welcome. And Phyllis, I'm very happy to do this again, and we can make a part 2, part 3. This has been really it's been enjoyable for me as well. So as your audience has more questions, I'm happy to come live, whatever it needs. I have a passion for this, and I'm very happy to help.
Yes. Okay. I'm gonna hold you to it because I'm all over it.
We'll get it scheduled. Thank you.
All right, we will. Thank you. Have a blessed day.
Bye-bye. Thank you.
Bye-bye. And I hope that you, our listening audience, will consider it an honor to share the Gornett Cancer Society nonprofit spotlight with others. Hey, have a watch party. Be sure to subscribe and stay informed with our powerful spotlights. And don't forget to follow us on Facebook, Gornett Cancer Society Facebook page for community events I know you won't want to miss. Until next time, know that your pathology matters.